Okay, so if we look at all the past lectures, I think there are close to 40, I think, right? And from the last time I taught, which was some time ago, I asked the registrars and the students to give me a list of topics that has not been covered. So in addition to what has been covered, I was given another list of about 20 topics, about 10 from obstetrics and about 10 from gynae. So I will, what is your name, Puta, the one who spoke with me just now? Abesi Rivardhan, what is your first name?
Setumini, sir.
Yeah, Setumini. So what I'll do is I will put up the current that list into this Telegram group, right? And then I want you to have a look at it and add any other topics that are required. It will also have the number of lectures that are already there. So then what I need is an additional ones. And if they are not reflected in the list that says that I have not covered them, then please add on, right? Any topics that you all want me to do. So before I, then probably your exams are in November, right? November? When? November when? You all have to unmute yourselves before you speak.
November 11th, sir.
All right, okay. So what I will do is closer to November. I'll be out of the country from October, late September to mid-October, most probably. So then towards the exam, I will do some other classes like how to face the clinical exams, all that. I will do a few classes there, right? For you all who have, it's best if you look at the videos that I have shown how to do an examination for a gynae patient, how to examine an obstetric patient, how to take a history, how to present the history. All the videos are there, right? Have you all seen those? Right? Check those because that will give you the base of what you all need to do during your exams and especially your clinical exams, right? Okay, today one of the topics that I was given was rhesus isonization. So it's a small topic. So I thought I'll just cover it for a start and then we'll go on to other topics, right? Does anyone have anything to say before I start? Any questions, queries? Anybody can unmute themselves and speak, right? Is there anything specific, any request? Because I don't know any of you all. I have not seen this batch at all, right? But this group has more than 4,000 students who are registered here who watch these lectures. So it doesn't really have to be, you know, from Jayawardenepura or anything. Anyone can ask a question or, you know, or you all can type in the questions if you all want to. Or any suggestions, please type in while the session is live, right? Okay. Right. So, and any time, please raise your hand. Not physically, you know, this will give you the facility to raise your hand. I think there's something here somewhere, right? So then I'll answer those questions if necessary. Okay, right. Okay, I want some more of you all to come on video because you know I don't like teaching to just a screen, so that is not very good, right? Okay. Right, okay. Can you all hear me clearly?
Yes, sir.
All right, fine. Okay. So let's start with rhesus isoimmunization. It's a short topic, but you might get it for your exams, and it's something practically also that you all need to do. Right. So let's start. Now, if you look at all the important isoimmunization conditions in pregnancy, then rhesus D isoimmunization is the most important, right? And it is the most commonest. What you remember is, what it means is there are basically, if you look at isoimmunizations, right, we have to understand how isoimmunization takes place. Right? The fetal red cell, as well as the thrombocytes, right, the fetal thrombocytes, they express antigens on their surface. And these are maternal as well as paternal antigens, right? So if you look at a red cell, or even if you look at a thrombocyte, right, on its surface, you get these antigens, which can be maternally and paternally derived. Our problem is mainly with the ones that are paternally derived, right? And when a rhesus negative woman, right, has a baby who is rhesus D positive, right, then the fetal blood cells will contain the, or sometimes contain the rhesus D positive, or a rhesus D positive baby will contain the rhesus D antigen on its surface. So what you have to remember is that the maternal and the fetal circulations do not directly link with each other. So it's always indirect, because the baby has its own heart, it has its own circulation, and the baby's heart pumps the blood out. It goes through the, comes down the aorta, right? Goes into the internal iliac arteries. From the internal iliac arteries, there are two umbilical arteries, right? And those umbilical arteries go on to the placenta through the umbilical cord. It circulates inside the placenta, and the same momentum or the energy that is given by the heart makes the blood go through the placenta and back to the baby's heart via the umbilical vein. So it's always a complete circulation. Remember, the placenta is always a very low pressure system. Otherwise, the baby's heart cannot push the blood through into a complete circle or a cycle, right? If it is a high pressure. For example, in problems with placental disease, right? When the placenta is not functioning properly, this low pressure system inside the placenta becomes a high pressure system. And therefore, the baby finds it difficult to pump blood through the placenta. So we are not talking about that actually. I just wanted you to, understand this. So the baby's circulation is on one side and the maternal circulation is on the side, and the exchange takes place at the intersurface of the maternal and placental vessels. However, it's not absolute 100% where the fetal circulation is completely separate from the maternal. It has been found that there is always an exchange, especially some cells or the baby cells, they escape into the maternal circulation, right? And when it escapes into the maternal circulation, and if the baby is positive and the mother is negative, suddenly when rhesus D cells get into the mother is going to recognize it as a foreign antigen, something that is from outside. And then what the mother is going to do is to form antibodies against this, which are called anti-D antibodies. Okay? It's not only D. There are other lots and lots of types of antibodies that can be formed, but the main one is anti-D. The two other important ones are anti-C and anti-K, right? Which to a lesser extent might cause problems, but the main one is rhesus D. So the mother forms these antibodies, but usually the amount of anti-D antibodies that the mother can form during the first pregnancy is not great enough for it to cross back into the baby and attack the baby's blood cells, right? Although a certain amount of attack takes place even during the first pregnancy, although the red cells of the baby might get destroyed, baby's erythropoiesis far exceeds the destruction that takes place. Do you all understand? So therefore, although a small amount of destruction, the baby manages to develop or produce more than enough erythrocytes. So therefore, no anemia takes place. And usually during the first pregnancy, nothing major happens. However, in subsequent pregnancies, now the mother is ready because the mother already in the blood cells, already her system knows this. And so the memory cells are there. And suddenly, if she meets with the antigen again in the subsequent pregnancy, she will mount a huge attack. And all those antibodies are going to cross onto the fetal circulation. And if the baby is rhesus D, it will coat the baby's blood cells. It will be destroyed in the fetal circulation. The amount of destruction far exceeds the fetus's ability to produce destruction here, but it cannot produce that much, so the baby has anemia. Depending on the extent of anemia, the baby can have a lot of problems. The baby will develop anemia, then baby, because of this anemia, the fluid in compartments will start to go up because the oncotic pressure inside the vessels, which is reduced. So therefore, it cannot hold the fluid inside the fetal blood compartments, and therefore they tend to go out. When they go out onto the tummy of the baby, you have ascites. When they are going to the pleural cavities, you have pleural effusions, right? And and when it goes onto the skin, the baby swells up, right? And we get what we call the hydrops fetalis, which is very severe disease, and the baby can die. So this is the problem with isoimmunization. So the whole challenge now is to prevent isoimmunization, because if it develops, then it's a huge problem to treat, right? So the best thing that can be done is to prevent isoimmunization. So let's look at the instances where isoimmunization can take place, right? Which means, what does that mean? Basically, what it means is, what are the instances where the baby's positive red blood cells cross over in large quantities to the maternal circulation that can cause isoimmunization, okay? It has been thought that it has been found out that even 0.25 ml, right? 0.25 ml of the fetal blood, if it crosses over the maternal circulation, can cause rhesus isoimmunization, right? So that's a very small amount. And so, therefore, what can be done about this? Can isoimmunization or the production of maternal antibodies be prevented when this takes place? For us to understand that, we have to know when it happens, okay? And therefore comes the understanding of what we call sensitizing events during pregnancy. Is that clear, children? Right? Remember there can be sensitizing events during pregnancy. But at the same time, what we have to understand is sensitization very rarely may occur without us or without us knowing that there has been an event. And these are called sensitizing events. These are called silent feto-maternal hemorrhages. Okay? So sensitizing events can happen that can cause the fetal blood to cross onto the mother's side, or it has been also found that a very certain amount, it has very silent crossovers during the pregnancy, especially so after about 28 weeks of gestation, right? So there are two areas in which you need to remember. If you are asked, okay, when does isoimmunization occur? In your brains, you have to remember that there can be a sensitizing event, right? Which is obvious to us, and we know it, we find it, and we can take action. Okay? At the same time, there can be silent feto-maternal hemorrhages that can cause isoimmunization. So therefore, if we want to prevent isoimmunization, especially to prevent its effect in the later pregnancies, we need to address both these two areas. Okay? We need to address the obvious sensitizing events, as well as we need to address these silent feto-maternal hemorrhages. So we will discuss both of these two. Now, if you look at some numbers, remember the amount of that requires for a woman to be sensitized is just 0.25 ml. Okay, that's very, very small. Okay. The second thing what we have to remember is how are we going to prevent isoimmunization? So what needs to be done is to neutralize the fetal blood, the fetal positive, rhesus D positive blood that gets into the maternal circulation. So we have to give something to the mother, right? Obviously, we can't give anything to the baby because the baby is inside, and there's nothing to be given because the baby cells are rhesus D positive. So therefore, we have to treat the mother. And what do we give to the mother? We give antibodies against the fetal rhesus D positive cells, right? So we give anti-D immunoglobulin to destroy the rhesus D positive red cells in the maternal circulation. Is that clear? Right? So, how or what is the amount that we give? Right? So we have to inject the mother. And what is the amount that we give? It has been known to neutralize, right? To neutralize 1 ml, we need at least 125 international units of rhesus D antibodies as an injection, right? So usually the injections are, you get 250 international units, you get 500 international units, and there are injections of 1,500 and in various dosages in between. Okay, the lowest dose is 250. So if you give a dose of 250 ml, international units of rhesus D immunoglobulin, that will neutralize a feto-maternal hemorrhage of 2 milliliters. Is that clear? So if you give 500, that will neutralize a feto-maternal hemorrhage of 4 ml, right? And if you give 1,500 international units, it will neutralize how much? How many milliliters? Calculate.
12, sir.
Sorry?
12, sir.
Yeah, okay. So therefore, we, number one, is we have to understand how much of fetal blood can be transferred across the placenta to the mother during the sensitizing events, right? So here, research has shown us that there is usually, if any sensitizing event happens before 20 weeks, right, the amount that is required to cover this fetal-maternal hemorrhage is usually 250 international units, right? Okay. And any sensitizing event that happens after 20 weeks, it is always best, or we need to give them a covering dose of at least 500 international units, right? So now first, let's look at these sensitizing events that we speak of. Remember, there are two large areas, right? The first large area is where there is a sensitizing event. And the second large area is where there are silent fetal-maternal hemorrhages, which we will address later. What are these sensitizing events? Number one, if there is miscarriage, right? If the patient miscarries, or if there's a threatened miscarriage after 12 weeks gestation, it is thought that some amount of blood would have crossed from a rhesus D positive fetus to a rhesus D negative mother, right? So that is number one. If the miscarriage is before 12 weeks, right, then of course it has been found that it is not necessary for us to give rhesus D because the amount of blood contained in that fetus is extremely small. So therefore does not cause isoimmunization. But it has been found that still, if the miscarriage was with a lot of bleeding, even just before 12 weeks, maybe 11 weeks or anything, right? Or if the miscarriage was with a lot of pain, still there is a place for us to give anti-D immunoglobulin. And what is the dose that we give before 20 weeks? It will be 250 international units, right? But however, a sensitizing event is miscarriage or threatened miscarriage after 12 weeks gestation is considered a sensitizing event, and you need to give rhesus D antibodies. Okay. If there's a medical or a termination of pregnancy. Now, termination of pregnancy in Sri Lanka is not legal, right? However, termination of pregnancy is done when the mother threatens suicide and when two consultant obstetrician and gynecologists and a psychiatrist must sign to say that the mother's life is in danger and therefore termination is indicated. Only in that case, termination is legal in Sri Lanka. But as general knowledge, what you have to remember is any medical or surgical termination of pregnancy in a rhesus D negative woman requires anti-D injections, right? And what are the other types when, because the blood can mix. So that is the reason that this is done. For example, if there is, even in a cesarean section, right? If you do a cesarean section and the cesarean section is very traumatic, right? And it's difficult cesarean section, still it is considered a sensitizing event. Sometimes if you do a manual removal of the placenta, that is also considered a sensitizing event. Any stillbirth, if the baby dies in utero, right, immediately within 72 hours, we have to give anti-D, because as soon as the baby dies, the integrity of the placenta might fail and therefore you can have transfusion of fetal blood into the maternal circulation. So you need to cover that immediately. So you understand any other intervention like external cephalic version, where you try to turn the baby from breech to head, right? If she is having bleeding, which is called antepartum hemorrhage, right? Before 24 weeks, it will be called preterm miscarriage. After 24 weeks, it will be called antepartum hemorrhage, because 24 is the place where we think that the fetuses are viable. So therefore, after that, we call it antepartum hemorrhage. And usually even after 20 weeks, it's called antepartum hemorrhage. So there is a sort of gray area between 20 and 24. But what you have to understand is, if there's antepartum hemorrhage in a rhesus D negative mother, we have to give them anti-D prophylaxis, right? Any trauma to the tummy, right, of the mother, then we have to give anti-D. And any procedures that are performed, like amniocentesis, corneovillus sampling, right, that we have to give anti-D. And also any ectopic pregnancy. Obviously, if there's an ectopic pregnancy, and if we have to operate on it, or if it is leaking, right, we have to give anti-D, right? So those are the, what else? HMOL. You know that HMOL, right? If, because it bleeds continuously, it can bleed continually. Also, you will need to give anti-D to this mother. So these are the sensitizing events that you have to understand that we have to give anti-D. Is that clear, children? Right? And what does anti-D do? Simply, you give it to the mother. This circulates in the maternal circulation. If they find a rhesus positive cell, it will cover it and it will take it off the maternal circulation without the mother forming antibodies and T cell memory to this particular antigen. Is that clear? Right? So we are trying to prevent isoimmunization. Okay. The next thing I need to tell you is, let's look at the other area before discussing other things. Look at the other area. How are we going to treat silent fetal-maternal hemorrhage? Right? Because despite the fact of us giving rhesus D antibodies during sensitizing events, it has been found that still, without sensitizing events also, women become isoimmunized towards the D antigen, right? And the reason that has been found is that there is silent fetal-maternal hemorrhages. Silently, little by little, without any obvious sort of show to us symptomatically, the red blood cells of the baby will escape into the maternal circulation. Now, to prevent this, the concept of routine anti-D prophylaxis has been brought, right? It's called routine anti-D prophylaxis. What does that mean? Every pregnant woman, every rhesus D pregnant woman, every rhesus D pregnant woman is given a routine anti-D prophylaxis in the hope that we will prevent or counteract the silent fetal-maternal hemorrhages. And it is started at 28 weeks. So the first dose is given at 28 weeks, right? And the second dose is given at 34 weeks. Why is there a gap of 6 weeks? Because once this anti-D is given, it works for 6 weeks, right? And therefore, it works in the mother's blood for 6 weeks. And then at 34, you give another dose. And then what happens is that works till 40 weeks. And then after delivery, right? If the baby is rhesus positive, then you give the mother postnatal prophylaxis. Right? So remember, prophylactic wise, there are 3 basic principles that you need to understand. What is the first principle? You cover all sensitizing events, regardless of whether the woman has had anti-D prophylaxis, right, at 28 and 34. Regardless of that, but each sensitizing event is covered. Is that clear? Regardless of the fact that the woman may have had a sensitizing event and has been given prophylaxis, still the woman has to get their routine anti-D prophylaxis, discarding the knowledge that there was a sensitizing event and that has been covered. Is that clear? Right? So one does not tangle with the other. They go independent. Any sensitizing event, you cover. The same time, regardless of whether there was sensitizing event or not, you give women the routine anti-D prophylaxis. Right? The third principle is, first principle is covering all sensitizing events. The second principle is routine anti-D prophylaxis. And the third principle is postpartum prophylaxis. After delivery, you give, because delivery is a sensitizing event, the far by the largest sensitizing event. Okay. Now, if you look at routine anti-D prophylaxis, right, there are two ways in which it's commonly given. At 28 weeks, you give, at 28 weeks, you give 500 international units, and at 34 weeks, you give another 500 international units. Some are in the practice that at 34 weeks, 1,500 is given, right? So, depending on the country, depending on the health system, two different doses can be given, a single dose at 34 or two doses at 28 and 34, which is 500 each, or 1,500 dose at 34 weeks. So different countries, different health systems will choose different ways, but you have to understand the system. In our country, of course, we would, if it's possible, we give it at 28, 500, and 34, another 500 international units, right? Okay, now let's look at the concept. Despite doing all these, right? So before 20 weeks, you give 250 international units. After 20 weeks, for any sensitizing units, you give 500 international units, and you give what is this? Routine anti-D prophylaxis at 28 and 34 or 34 one injection. And after delivery, even if we give 1,500, right, which is postpartum prophylaxis, still there'll be a certain number of patients, right, who will be isoimmunized despite giving all this. And what is the reason? Is that the amount of anti-D which we give is not enough to cover the fetal-maternal hemorrhage. What does that mean? That the fetal-maternal hemorrhage exceeds the amount of anti-D which we give. Remember, we have said that 125 international units will normally cover 1 ml of fetal-maternal bleed, right? So therefore, some of them very rarely exceeds 15 ml, which is more than whatever even 1,500 international unit covers, right? And how do we do this? Ideally, what we'll have to do is to find out the amount of fetal-maternal hemorrhage or quantifying the fetal-maternal hemorrhage. In an ideal situation, every sensitizing event, it's better to do a quantification of the fetal-maternal hemorrhage, right? After delivery, it is better to do a quantification of the fetal-maternal hemorrhage. And what do we do to quantify? Basically, what means to quantify is to find out the number of milliliters that has crossed over. Okay, and this is done by two methods. Right, one is the Kleihauer test, and the other is flow cytometry. Okay, Kleihauer test is available in most units. In Sri Lanka, it's available, right? But this cytometry may not be available too much, right? And what are these dependent on? Kleihauer test is dependent on the fact that if you put the maternal blood into a slide and put strong acidoalkali, right? The maternal red cells become like ghost cells because they are not resistant to strong alkali or acid, right? And then only the fetal cells will be left. And therefore, you can count these, right? And calculate by special methods the amount of fetal blood cells in the maternal blood, right? And then you can say, yes, this is the number of milliliters of fetal blood that has come into the maternal circulation, right? However, you have to remember that the Kleihauer test does not differentiate between rhesus D and rhesus negative fetal blood cells. Because the baby may be, although the father may be positive rhesus D, still the baby may be negative if the father is heterozygous. You all understand? If the father is homozygous because they follow the Mendelian way, right? So if the father is homozygous, right, for the D antigen, definitely 100% the baby is going to be rhesus D positive. Is that clear? If the father is negative, heterozygous for rhesus D, right, then the baby can either be negative or positive inside the mother's womb. However, if that is not known, and how can this be known? We can test doing free fetal DNA. What does free fetal DNA mean? Right? If the mother is rhesus negative and the father is rhesus positive, right? Then if we know that the baby is rhesus negative, then we don't need to do anything else. Okay? And how do you find out? You take the maternal blood and the baby's DNA is floating in the maternal blood, usually detectable even at early stage, but easily detectable after 11 or 12 weeks. So the maternal blood can be taken, which is a non-invasive test. The baby's DNA is isolated, and we can check whether the baby is rhesus D positive or rhesus D negative. Of course, if we find out that the baby is rhesus D negative, then of course we don't need to worry too much. However, if the baby is rhesus D positive, then of course isoimmunization can take place. Is that clear? Right. Now, the Kleihauer test. If we find out that the Kleihauer is positive, right, then of course, and if we find out that the hemorrhage is, say, 20 ml or 15 ml or whatever, right, then we can calculate easily the amount of rhesus D antibodies we need to give the mother to cover that that particular fetal maternal hemorrhage. Is that clear? Right? If you want to further look into this, because remember, Kleihauer test does not differentiate between the baby's rhesus negative cells and the rhesus positive cells. Because just because there is fetal blood cells, right, in a rhesus negative mother does not mean that the baby is rhesus positive. So therefore, if you do flow cytometry, then of course, it is possible to recognize whether these cells are rhesus D negative, baby cells, or rhesus D positive. How is that done? A special fluorescein antibody is put in and it combines with the rhesus D cells and there is fluorescence, right? And therefore, that way by all the specific sort of analysis, you can find or you can check the quantity or they can tell us the amount of fetal maternal hemorrhage that has taken. So the Kleihauer test can be positive, but the flow cytometry can be positive or negative for rhesus D cells. Is that clear, children? Right? So if you want to, but flow cytometry is not is not easy to find and not a common thing. So therefore, sometimes we have to rely solely on the Kleihauer test. Is that clear? Right. So quantifying fetal-maternal hemorrhage is done by this quantifying test. One is, remember, the Kleihauer. The other, of course, is the what is this? The other one is the flow cytometry for these entities. Is that clear, children? Right? Right. So that sort of puts into perspective, right, this ways in which we manage this rhesus isoimmunization as obstetricians. So to summarize, what do we do? When a woman comes to us in the clinic, and if she is rhesus D negative, when you do the blood group, right? First thing in the mind, it says is, okay, and if she has had deliveries before, if she has had blood transfusions before, the first thing that should come to mind is this woman already isoimmunized? Because if she's already isoimmunized, there's no point in giving her any antibodies because she already has antibodies against rhesus D, right? So therefore, when a woman comes to us, to the clinic, we will test her for rhesus D antibodies, right? If it is negative, then of course we know that, okay, look, this woman is not isoimmunized. Good. Now we have to look after her throughout the pregnancy and after delivery, and to make sure that the woman does not get isoimmunized. And we do it in 3 ways. It is good if we know the husband's blood group. It is also good if we can know if the husband is heterozygous, or husband or partner is heterozygous or homozygous. But this information is rarely forthcoming. That is number one. Number two, the problem is paternity is not always 100%, right? Although the woman might claim that this is the father, that may not be the father, okay? And therefore, paternity is not 100%. So therefore, we do not rely on the we do not 100% rely on the father's blood group. Do you all understand? Right? And therefore, the next thing. So when the woman comes, okay, we do rhesus D antibodies. If it is negative, fine. Then we have to look after the woman. And how do we look after the woman? 3 principles. We cover each sensitizing event. We give routine anti-D prophylaxis, right? And we give postpartum prophylaxis if the baby is rhesus positive. Is that clear? That is how we do. And each time, if there's a sensitizing event, it's good if we can measure the fetal-maternal hemorrhage or quantify the fetal-maternal hemorrhage by doing a Kleihauer, and even better if you can do a flow cytometry. Is that clear, children? Right? So that is that. The second problem is what? The most is if the woman is rhesus already isoimmunized. So the rhesus antibodies come as positive, right? Then what do we do? What is the risk? The risk to the baby is if the woman is already isoimmunized, the woman has already antibodies against the rhesus D antigens in the baby's blood cells, right? So as soon, then what happens is the mother's antibodies will be produced in large quantities when it meets with a few red cells that has crossed over from the baby to the mother, and it will mount a reaction, and the antibodies will cross over to the baby and start destroying the baby's cells. And what does the baby develop? Severe anemia and high drops, right? And when the baby comes out, it will be having hemolytic disease of the newborn as well, right? So either the baby can die inside, or when it comes out also, there'll be so many complications that the babies face in due to severe anemia, and of course the large amount of bilirubin that are in the baby's circulation that can give kernicterus and damage, right? Because the baby's liver cannot process unconjugated bilirubin, because when the baby's blood cells are getting destroyed and there's a lot of bilirubin unconjugated, baby's liver cannot process that, and therefore it will go to the brain. It will also cause brain damage and kernicterus, right? So these are the dangers. And of course, or early on, it will develop hydrops, will go into heart failure and die, right? So these are the problems that the baby is going to face if the woman is isoimmunized. Now, what do we do? Number one, these patients, it is essential for us to refer to a fetal-maternal unit. Okay? Any fetal-maternal unit that is looking after these babies, or sorry, mothers or pregnancies, we can, in Sri Lanka, we have several, so we can refer them to these fetal-maternal units. And what do they do? Number one is they will, initially we will, or general obstetricians, we will monitor the amount of antibodies that are in the patient's circulation, all right? And we do that every 4 weeks until 28 weeks, and then 2 weekly after 28 weeks after delivery. And what are we looking for? We are looking for rising titers or rising amount of antibodies in the maternal circulation, which means the mother is mounting a reaction against the baby, right? Do you all understand? So therefore, what is done is, if the titers are going up, right? The titers are going up, then we will need to take some action. One moment, I just need to take a call. Okay, sorry. Where was, right. We are talking about you're talking about the quantification, right?
About rising titers.
All right, sorry. So, okay, so when if the woman is found to be positive, what we do, or what is done is, we test her for antibody titers. And what are we looking for? Usually, if the antibody number of antibodies, right? If it is less than 1 international units, or sometimes less than 4 international units per liter, right, in the mother's blood, it's highly unlikely that the baby is going to develop hemolytic disease, right? If it is more than 15, then the risk is very high. Okay, so therefore, or if the titers are rising, then the risk becomes more and more. So therefore, if the titers are rising, or if the titer is more than 15, right, then the chances of the baby having problems is higher. What is done then? So, baby, long time ago, the babies of this sort, these affected babies, developed hydrops fetalis and died very early, right, inside. Okay, hardly ever were any babies born, right, of the women who are affected severely. Then a new concept came into being. Why not try and perfuse these babies or give them blood while the baby is inside the tummy? Okay, so the first person who brought this concept is called Lilly, right? And what did he do? So the problem is anemia, right? The baby, it's impossible to prevent the antibodies crossing over from the mother to the baby. Then the concept came, okay, let's treat the baby. Because the problem is anemia, then let us transfuse the baby. And when, the next question is, okay, when do we transfuse the baby? In the early days, the first problem was detection. That is, when do we transfuse the baby? And how that was thought about was serial amniocentesis was done, right? Starting from you put a needle into the mother's tummy or into the inside the amniotic sac, and the amniotic fluid was drawn out. And in this, the amount of bilirubin was measured by a method which we don't need to discuss, right? The amount of bilirubin was measured. And then indirectly, depending on what is called the bilirubin bulge, or the amount of bilirubin in it, indirectly, the amount or the baby's hemoglobin was calculated. Okay, so basically the more bilirubin that is there in the amniotic fluid, the more anemic the baby is. And how does the amniotic fluid represent the baby? Because it's mostly baby's urine, right? So because you know mainly that the baby urinates, and therefore it's the amniotic fluid, and then the baby swallows it. So it's a sort of a circulation, right? If there is less urination, if the placenta perfusion is not good and the baby's kidneys are not perfused, and the baby urinates less, you get oligohydramnios, or there'll be less fluid around the baby, which can happen during placental insufficiencies, right? Anyway, that is beside the point. So Lilly drew charts, right? He drew some beautiful charts, just look them up, right? Where he has, with the gestational age, these charts will show whether the baby needs to be transfused or whether we can just watch, or the baby doesn't need to be transfused. Okay, so serial amniocentesis was done, and it was charted, put in the chart, and it was checked, okay, whether the baby needs to be transfused. Now, how does transfusion occur, right? What Lilly did was, he transfused the baby, but the transfusion took place into the baby's abdomen. So a needle was inserted through the uterus, through the abdominal wall of the mother, through the uterus, right into the baby's abdomen, and the blood was put in there, right? So the baby absorbed the red blood cells from the baby's own abdomen, right? So serial transfusions took place. So therefore, when these transfusions took place, suddenly, dramatically, the babies who died early of hydroxypitalis started to survive. So that was the first major breakthrough in treating these babies' chance to live, right? However, as time went on, so doing serial amniocentesis, there's a risk of miscarriage, and it's a procedure which is complicated. Doing intra-abdominal transfusion on the baby is also complicated, and therefore complications can occur. And then with time, the Dopplers came in. And what is the Doppler? Doppler was used, or is being used now, to measure the amount of anemia the baby has by doing middle cerebral artery Dopplers, by finding out, because the thinner the blood, the faster it flows. Okay, the thicker the blood, the slower it goes. So therefore, Doppler measures the velocity of the blood, and therefore, by calculating the velocity of the blood by doing MCA Dopplers, middle cerebral artery Dopplers, or how fast the blood is going, you can calculate the amount of anemia that the baby is having. So therefore, the MCA Dopplers and the Dopplers were used to calculate how anemic the baby is. And depending on those new charts by the Dopplers, you can determine when to transfuse. And now in this age, transfusion is done, right, directly into the baby, into its blood vessels, right? Specifically, the umbilical cord is cannulated and the blood transfusion is given. And this is called intrauterine transfusions. So by finding out, so serial amniocentesis was no longer needed. And you can do directly, you calculate by the Doppler when transfusion must be given, and serial intrauterine transfusions directly into the baby is done, right, to keep the baby alive until about 32, 34 weeks, and then the baby is delivered, right? And therefore, suddenly the prognosis, not suddenly, over a long time, right, of all these developments by very knowledgeable and brave people, right, they made that these babies suddenly had a chance and are or is being born alive, right? So this is how in utero treatment is given to these babies for them to survive, and this is the treatment for women with already pre-existing isoimmunization, right? So that is basically all which I wanted to discuss with you all today, right? Remember, there are other entities. There is anti-C, which goes along the same lines, anti-K, which goes along the same lines, right? These are. Also, there are different kinds of thrombocytopenias, right? Where the thrombocyte in the baby can display paternal antigens which are not existent in the mother, right? And these thrombocytes, when they escape into the maternal circulation, the mother develops antibodies against these paternal antigens sitting on the thrombocytes, like the red blood cells on thrombocytes. And these antibodies will cross over to the baby and cause thrombocytopenia. Okay? And of course, there are other different hematological conditions that we need to discuss in obstetrics, like thalassemia, all those things, which we'll discuss maybe if it is important at a later date. These are not very important as far as this condition are, because they are not very common. But however, if we have time, we will discuss them. But remember, the most important topic in isoimmunization is research D isoimmunization, because that is the commonest, and so many advances have been done regarding this to treat the babies who are suffering from hydrops or anemia due to these antibodies crossing over to the baby, right? Okay, so that concludes our so do you all have any questions? There's one.
Yes, I have
One more,
one.
sorry.
Yes, I have one question. So if a medical termination of the pregnancy takes place,
Who is talking? Please
Yes.
come on. Where?
yes,
Yeah, you're sorry, sir.
yes.
Yeah, go on.
So if a medical termination of the pregnancy takes place before 12 weeks, still do we need to give anti-D
Yeah,
to the mothers?
because terminations will usually, they are closer to 10 weeks, right? So 10 weeks, 11 weeks maybe. So if it is a spontaneous miscarriage, no. However, it is a termination, or if it is closer to 12 weeks, and if she has had bleeding for some time, and also it is combined with abdominal pain, it is thought that it is safer to give it, right? And the amount that is given is about 250 international units, right?
Okay, sir. Thank you, sir.
Okay. Wait, there's another, somebody put in the chat. For an ectopic or H small, when should we give rhesus D, and does the dose depend on the time of discovery and how? As there is a higher risk than an intrauterine pregnancy. An ectopic, if it's an ectopic, is when you if it's a leaking ectopic, you need to give it, right? And it is better if you if it is quantified by a CLIA or a flow cytometry, right? H small, when should we give rhesus D and S? So we give for an H small, of course, we don't wait for it normally to go on its own. We will need to evacuate it. So it's best if it is given at the time of evacuation, right? Or soon after evacuation. However, at the same time, you can do, if it is bleeding, if the H small starts to bleed, then of course you give it immediately, right? If the H small does not bleed, and then you have to, when you are going to do a surgical intervention, right, to evacuate it, then you can give it. It's best if you can also quantify the hemorrhage if possible, right? And does the dose depend on the time of discovery and how? Best dose does not depend. Yeah, of course, it depends on the amount of the fetal maternal hemorrhage, right? So it's best for these instances, it's best to cover it with the maximum possible dose, right? You normally in our practice we will give 1,500 international units, right? That covers quite an amount. Say 500. I told you 125 covers about 1 ml, correct? Right? 250 will cover 2, so 500 will cover 4. So the 1,500 international units will normally cover about 12 ml of fetal maternal hemorrhage, right? So therefore, we will use that dose. There is a higher risk than an intrauterine. There is a higher risk area. So that probably is a question. Okay. Anything else? Any other questions? Do we routinely do free fetal DNA if baby's rhesus is negative? Can we omit the routine doses? No, we don't do routinely fetal DNA because it is very expensive. It ranges from, it's not available in the government sector, and it ranges from about 30,000 to 60,000, depending on the number of tests that you perform. I'm not exactly sure whether it can be performed only for the purpose of doing a rhesus D, right? So therefore, it is not routinely performed. And that is the first question. Can we omit the root? Yeah, if the baby is rhesus negative, we don't need to do anything because there is no ICM itself, right? So therefore, you can just omit all the, we don't need to do any sort of prophylaxis or anything. If we know 100% sure that the baby is rhesus negative, right? Next is, in an already ICU-immunized mother, is there any prophylaxis before pregnancy? No. Like, no, we can't do anything because if the woman is already ICU-immunized, the antibodies will already be in the memory cells, right? So as soon as it meets the antigen of a rhesus D mother, it will mount a reaction. So there's nothing you can do. Only thing is, some women will not mount a huge reaction. Some will not mount. So if the quantification is done during pregnancy, and if it is less than 4 international units, right, of anti-D, then the chances of the baby having problems is not that great. Especially if it is less than 1, it's almost non-existent. If it is less than 4, also not. Anything over 4 and especially over 15, the chance of risk is very high, right? So therefore, it needs monitoring. Remember, up to 28 weeks, every 4 weeks, and after 28, every 2 weeks, you have to quantify to see whether the baby is falling apart. And of course, with ultrasound follow-up of the baby's condition. But a baby will develop edema of the skin, right? Effusions of the cardiac, pleural, or the abdomen only in the late stages. So that's not a very good thing. The best thing to check for anemia is by MCA Doppler. So MCA Doppler is carried routinely for these babies, right? If a sensitizing event occurs in 34 weeks, do we need to give routine dose as well as in the, yes. Remember, routine anti-D prophylaxis and sensitizing events go independent, right? So you need to give that and that as well, right? So they don't interconnect. So usually you have to remember, once the anti-D is given, up to 8 weeks, the antibodies will be found in the maternal blood, right? And so if you do rhesus D antibodies with the purpose after giving rhesus D injection, and then you suddenly you do and say, oh, this woman is rhesus D or isoimmunized, remember that the injection also can cause her to have a positive result. Okay, do you understand? Right. If the miscarriage is before the 12th week of PUA, unless it's severely bleeding or painful, we don't need to give the antibodies. No, if there's no bleeding, that's no big bleeding, but it has been bleeding on and off for so long time, yes, you give. If there is no bleeding, but then suddenly starts to bleed and have miscarriage, but not very painful, then over. These are very gray areas, right? But less than 12 weeks, what is the reason that we don't worry too much? It's because the amount of blood in the baby is too small to isoimmunize, right? So therefore, however, if you feel or if there's a risk and you think it's necessary, then you can always give injection of 250 interaction units, right? Mother, so in Sri Lanka, mother antibody titers are measured routinely, even primary. Yeah, if a woman is rhesus D negative, as she comes in, rhesus D antibody test must be done. That is a routine test, or should be a routine test. You all understand? If a woman walks into a clinic and she's a primary or even a second one, doesn't matter which baby, she's rhesus D negative as she walks in in the first booking visit, along with the routine bloods, rhesus D antibodies need to be done. If it becomes positive, then you do the quantification of the antibodies to find out what is the titer. And then you follow up. And if it is going up, then of course the needs to be referred to a fetal-maternal unit to monitor the baby very carefully, right? And to have to intervene if necessary by the way of intrauterine transfusions, right? Is genetic assessment done routinely to detect whether the partner has? No, it's not done routinely. The biggest problem with checking the partner is that paternity is not 100% children. Do you understand? So although the person might say, okay, I'm the father, right? That does not mean that it is the father. Okay. So therefore, that is why in lots of countries, checking the father has not been a very routine thing, because it can change. You all understand? So therefore, whether the partner is homozygous or heterozygous, still this might not hold an absolute indication that the baby is going to be negative just because the father is heterozygous, right? Okay. Right. Okay. Time for all of us to sleep, I think. Right. So yeah, I'll try and do another class. I'll put this on for the, what is this? I'll put this on the link. I'll put this on my this, I'll put the link for you all to look at this again, the lecture, okay? Okay then, good night.
Thank you, sir.
Thank you, sir. Good night.
Thank you,
Yes.
sir, good night.